Hello, this is Chair Mike Freiberg. Pursuant to House Rule 10.01, I call this remote meeting of the Preventive Health Policy Division to order. The clerk will take the roll for attendance.
Representative Freiberg.
Here.
Representative Bierman.
Present.
Representative Grunhagen.
Present.
Representative Aiken.
Present.
Representative Igbaje.
Present.
Representative Eklund.
Present.
Representative Carlson.
Present.
Representative Franzen. Representative Heinzman. Representative Morrison.
Present.
Representative Pryor.
Present.
Chair, you have a quorum.
Thank you. The next item on the agenda is the approval of the minutes of the January 27th meeting of the division. Could I get a motion to approve the minutes?
I'll make a motion, Mr. Chair.
Thank you. Vice Chair Representative Bierman moves approval of the minutes. Any discussion? All those in favor, please say aye.
Aye.
Opposed? Motion carries. The minutes are approved. So today I've asked a couple experts to come here to talk about childhood immunizations. So we had a presentation a few weeks ago about the COVID vaccine specifically, but another issue that's been a related issue that's been a topic before the legislature is the issue of childhood vaccines. I know when there was a measles outbreak a few years ago, this came up in discussion, and there's always a lot of times there's discussion around the exemption language related to children going to school. So it's a topic here, and I know there's a lot of information out there. There's also a lot of misinformation, so I thought it would be good to hear from some experts in the field. I'm going to ask, like I did last week, I'm going to ask members to hold questions until the end, but we only have 2 testifiers, so there should be plenty of time for member questions here. So with that, I think Dr. Grabenstein, I think maybe you were going to go first. If you could just please identify yourself for the record and then proceed with your testimony, we would appreciate it. Thank you.
So thank you very much. My name is John Grabenstein. I actually have a slide. May I have permission to share my slides?
Yes, I believe my staff can make you a co-host, and you can. There you go.
Can you see them?
Yep. Yes, I see them.
Okay, there we go. Great. So thanks. You asked me to introduce myself, so I'll go to this slide next. I'm a pharmacist. I have a PhD in epidemiology. I served in the United States Army for 27 years, and my terminal job was to direct the Military Vaccine Agency, which was the vaccine coordinating group for the 5 military services: Army, Navy, Air Force, Marine Corps, and Coast Guard. I retired from the Army at that point. I joined Merck Vaccines outside of Philadelphia, where I was the executive director for global medical affairs. So I got to do a fair amount of, I knew a lot about vaccination policy in the United States, and I ended up learning a lot about Europe and Australia and Japan and a whole variety of other places. I retired from Merck at the beginning of 2020 and formed a little consulting company, sole proprietorship. My major part of my week goes to editing the newsletter for the Immunization Action Coalition. That's my Minnesota connection. The IAC has been based in St. Paul for 30 or 35 years, something like that. And they provide practical resources for vaccinators based out of a website called immunize.org. I live in Easton, Maryland. What we propose today is for me to start, and then for Dr. Bob Jacobson, who I've worked with over the years, to follow. I would propose to take you through essentially where vaccines come from, and how do we know that they work, and how do we know that they're safe, and then monitor them. And then I've also, as I'll explain, I've spent a fair amount of time thinking about vaccines and religion, and I'll give you the benefit of some of my research on that topic. Dr. Jacobson will follow and talk about the value of vaccines, vaccine hesitancy issues, and what's happening in vaccine practices as the state of the art, essentially. So a vaccine is, or vaccines are a class of medication. They trigger an immune response to promote immunity, to protect people from specific diseases or infections. Vaccines don't protect directly themselves. The act of vaccination, putting the vaccine into the body, induces immunity against a future infection. And of course, the body does this naturally, defending itself against infections. But vaccination is a way of taking science and getting specific immunity against the diseases we most want to prevent. Society's expectations of vaccines are extremely high. Other than clean water, no other medical intervention has saved as many lives. That includes antibiotics, kidney transplants, cancer chemotherapy, heart disease, insulin. Nothing has been as effective in prolonging life, saving lives, prolonging longevity as vaccinations have. Society expects that vaccines be the safest of all medications, and that's because vaccines are given to healthy people to keep them healthy. Vaccines are actually studied in larger populations than any other drug, any other class of drug. I kid my friends who are involved with cancer chemotherapy that they can be participating in trials that with 200, 300 participants can get a cancer chemotherapy license by the FDA. But a vaccine requires studies of 20,000, 40,000 or more people. And then even at that point, the safety surveillance systems that are operated by the federal government, by university systems, by a variety of sources, all continue infinitely for as long as those vaccines are distributed. This is a copy of a license from 1916, and I'll explain this. So the federal government first began regulating vaccine production in 1902, and the authority was housed in the Treasury Department at the time, and this license is about the size of a college diploma. And this particular one, it goes to the H.K. Mulford Company. That was Merck's predecessor company out of Philadelphia, and it's 1916. In all the fancy script there, it's authorizing the production of products to be introduced into interstate commerce, and then it lists them all. Each of the products that the company was authorized, and these licenses were renewed. Not all of them are surviving in the archives, but they were reissued annually after an unannounced site inspection in 1916. And I have circled in red some things I'm going to amplify on the next slide, and they look to me as if they are check marks. Like the site inspector came in and said, yep, we saw that one, and yep, we saw that one, and yep, we saw that one. And just fascinating to me how things used to be done 105 years ago. But it's now 105 years further along, and the internet, of course, helps us by letting the public see how the Food and Drug Administration regulates vaccines. And this is a relatively new site that FDA's put up to help folks understand the intricate efforts that they take before they let a vaccine become distributed into interstate commerce nowadays. And this is just one of the FDA divisions, but it's the part of FDA that it is responsible for the site inspections, for the lot release programs. Each lot has to be individually released by the FDA before it can be used, and there's lot release specifications that must be reached. And this website explains all the fine detail of what just this one subdivision of FDA does. You may well have covered this in that previous session on COVID vaccines, so forgive me if it's a bit redundant, but it just shows the progression from a bright idea about maybe some university professor or manufacturer has an idea for how to prevent some new disease. So with COVID vaccines, that back in February, you hear stories about beginning to figure out how we're going to make a vaccine, and then the earliest stages are cell culture studies or animal studies that are looking to see whether that product, that vaccine candidate, can induce an immune response. How does it work over time? That's the kinetics part of it. Is it safe? What are our first indications of toxicity in mice or in rabbits, perhaps? And then eventually, if the FDA permits, that candidate can progress through early studies, mid-stage studies, later stage studies, very conveniently 1, 2, and 3. And the big difference is the scale. Dozens of people, hundreds of people, all volunteers. And then I was kidding around about cancer drugs, but even heart disease drugs may not be in all that, in a few thousand people. But vaccines, it's typically tens of thousands. And then first, those first in human studies, you notice that safety is there as the dominant data collection with all those studies, but just does it do in people what the rabbits or the monkeys suggested that the product might do to prevent disease? Several doses might be tested. It's called dose ranging. And if that looks good, then the company applies for permission to proceed to phase 2. Safety again, immune response, maybe narrowing down the dose to a choice or two, a few hundred people. And then eventually come the pivotal studies, the ones that are going to look for disease prevention, vaccine efficacy. These are the ones we got so excited about with COVID in November, when it was fine. We'd seen these data earlier, but these phase 3 studies on the Moderna and the Pfizer vaccine came along in November. And those are tests of what the expected dose is. Then comes licensure. In the Food, Drug, and Cosmetic Act, drugs are approved and vaccines are licensed. That's the point by the tradition of the law. That's the mention on there. But I actually don't have here what we've just realized, which is that in an emergency, FDA has authority that it hadn't used very much, called emergency use authorization. EUA was the way that a lot of COVID tests became available quickly, but it was also the way that these first 2 vaccines became available to Minnesota and the other 49 states in December, mid-December. And so so when this phase 3 trial is done, then the company applies to the FDA for the licensing status. And it literally, because of the detail that the FDA goes to, it literally is it's the electronic equivalent of 100,000 pages, literally, of submission. Each participant's story goes in for the FDA to review. Well, it takes the FDA months to read all that. Meanwhile, we had the pandemic, so the FDA used its EUA authority to make the vaccine widely available, still with controls. Those vaccines have not yet reached the licensure phase, which would presumably come in a few months. And happy to go into detail on that if you want. The surveillance never stops. Sometimes called phase 4 studies, sometimes called post-marketing surveillance. Everybody wants to know how long those vaccines will protect. We don't know. That's the durability part of it. But last Wednesday, the CDC presented to the public at an advisory committee meeting its safety findings so far with the mRNA vaccines, the Moderna and Pfizer vaccines. So that's the first report of this kind of safety data. And these are, of course, in this case, millions of recipients. And so we can get quite intricate in the analyses that can be done. This on the right-hand side of the screen is a screenshot from this CDC website showing all of the different safety surveillance programs that various parts of the CDC, the FDA, universities, Department of Defense, the Indian Health Service are operating to look at the widespread use now of the COVID vaccines. And in this box, I've tried to categorize these studies by what they contribute. And I've ranked them by their scientific power to get to causality, to cause and effect. And the program people know a lot about is a program called VAERS. That's the Vaccine Adverse Event Reporting System. And that is a collection of cases. Something happened after vaccination, a healthcare professional, the manufacturer, the public submitted that information so it could get collected and compared to a bunch of other case reports. And the CDC calls this its early warning system. So this is sort of the base. And then cases can be looked at by expert clinicians. That's called CISA. So you probably have seen in the news about severe allergic reactions rarely with the COVID vaccines. They've gotten evaluated by CISA physicians. Mayo Clinic may participate in this, and Bob can probably tell us about that if so. Scientifically, the most powerful of the studies are the ones that compare millions of vaccine recipients to millions of unvaccinated recipients. And that's powerful because it helps us separate wheat from chaff, helps us separate what's a background event. You know, people get cancer, people get heart attacks, people get all sorts of things, even if they're not vaccinated. If that happens after vaccination, should we blame it on the vaccine or not? And so that's the ones over here that are the Vaccine Safety Data Link, VSD. The defense version of that is the Defense Medical Surveillance System. I worked with them a lot when I was in DoD. FDA has one called BEST. There's a Sentinel initiative. The key point here is that the scientific power, the scientific rigor that can be used to identify whether a problem is a signal or a real source of concern comes from these kinds of studies. And I've been using COVID-19 examples, but these also apply to childhood vaccine examples, and this sequence of events also applies to childhood vaccines more slowly. It takes more years with children to get through this sequence, but it's the same sequence. I want to take you back to 1976. This is Gerald Ford, of course, and this is the influenza New Jersey or swine flu program of that year, because there's two stories I think that are useful. One that it was a false alarm, and one that was a true alarm, and I'd like to take you through that a little bit. So in early of 1976, folks thought there was a new dangerous type of influenza circulating. It was isolated, but it was a cause of alarm. And so the government organized the manufacturers to start making vaccine. There was a mass vaccination program starting, I think, in August or so. And it proceeded along. In October, 3 people died of heart attacks on the same day in Pittsburgh, a few hours after they got vaccinated. And the newspaper headlines were bold, and there was alarm and hurry up committees and what have you. And eventually, folks realized, wait a minute, how many people get a heart attack in a big city every day, per day? Once one day's worth of heart attacks in Pittsburgh. And the answer was 10 or 12 or 15 for this age group. And they realized that this was coincidence. This was not unexpected. The heart attacks were expected. It was just what was new was they happened to have gotten vaccination a few hours earlier. And when the statisticians, put all that together, they realized that the rate of heart attacks was not higher than the number of heart attacks that would be expected normally. So dismissed, not a true cause and effect relationship. But in November, there was one, and then another, and then another, and then another case of Guillain-Barré syndrome. Guillain-Barré syndrome is a neuromuscular paralysis syndrome. My sister actually had it a few months ago, and last year, I guess. And it happens in unvaccinated people. She was not vaccinated with anything. But it happened in some of these influenza vaccine recipients. And in fact, when the statisticians put all the numbers together, they realized that the rate was 4 times higher than the rate of Guillain-Barré syndrome in unvaccinated people. And so the vaccine was to blame here. And this one was a true cause and effect relationship. And so the message here is things will happen, and it's important for us to use our brains, use science to figure out whether it's a false alarm or a true alarm. Now, in just the end of the story, there wasn't as much influenza as people expected, and so the vaccination program was stopped because there was no disease to counter. That's, of course, a far different situation than we face with COVID-19 today. Okay, so I just want to pick up a couple of practical matters. This is, those of you who speak German or a bit of German know that Impf is the word for vaccine in Germany, and this is what taking the COVID vaccine to the people in Nuremberg looks like. But I put that in just to transition to some practical things. These are standards of vaccination from a paper I wrote a long time ago. But I just want to assure you that, and I'm very confident that the Minnesota Department of Health approaches all of its vaccinations with exactly this intent, that there be high quality standards for vaccine delivery, for site preparation and the like, that people the potential recipients are well informed about what the vaccine that is proposed for them contains, what its effect is, who should and shouldn't get it, that the sites are well prepared for storage and handling. Of course, these mRNAs need freezing or ultra freezing, and so there's been some extra strain in the last few months. Checking people's histories, looking for reasons not to vaccinate them, contraindications, bars to vaccination, and taking a good history, giving the right dose at the right route, and making sure it's in a setting where there's epinephrine available, adrenaline available right away to treat severe allergic reactions if they happen 1 in 200,000 cases. Good documentation, highly important. Monitor, and then the monitoring for adverse events that I've described several times. Vaccines have been described as victims of their own success. People forget what the diseases looked like. My parents, I see a bunch of youngsters on the video, so your grandparents, were very attuned to having kids quarantined or the like. This is an iron lung. If you get poliomyelitis, your diaphragm can be paralyzed. You can't breathe, and so this was a mechanical device that did your breathing for you. But these people were in those iron lungs for months and years, and really a remarkable thing to have the burden relieved from us. Jonas Salk commemorated in a stamp Elvis Presley getting polio vaccine to encourage teenagers to get vaccinated, because there were a bunch of teen polio cases at the time. I had seen this picture long ago, but I only found out in the last few weeks. This was just several minutes before he performed on the Ed Sullivan Show. And so people don't know, he was singing Blue Suede Shoes or something, and he had gotten the vaccine just 10 minutes earlier. And of course, rubella is a major cause of birth defects. My cousin's wife was pregnant during the big rubella outbreak of 1964, and her son, or my cousin Ricky, has survived, but has major birth defects from his mother having rubella while she was pregnant. So these diseases, while they have disappeared largely, are nothing that we want to return to, and it's highly important to keep up solid vaccination programs. Okay, let me transition and talk about religion a bit. Vaccines, are given to people in society, and part of people in society is various religious beliefs. So
Just so you
naturally,
know,
it's
Dr. Gravenstein, I'm sorry, I'm getting that wrong. Just so you know, I'd say maybe try to go about 5 or 10 more minutes. We want to make
yes,
sure.
I'm
Dr.
almost done.
That's fine.
I'll,
Okay,
I'll
great.
go quickly here.
Thank you.
Sorry, thanks for the reminder. Anyway, so back in 2003, I did a review of all of the major religions, every religion with more than 5 million adherents. So it's everything on this list. And then I did all the Christian denominations that you see there. There are certainly, we certainly should be considering individual rights, but we also have to think about collective duties. And, you know, in Genesis, that comes from Am I my brother's keeper? What I found was 60 reports of vaccine preventable outbreaks in religious congregations or communities or schools. This list of diseases, and they spread, you know, the virus doesn't respect borders, so it many times did spread from the religious cohort to surrounding people of other religions. And measles and pertussis 6 to 35 times more common among people claiming religious exemptions. So they are at risk if they exercise this right. I think this is my last slide. I'll just focus on a few here. Judaism, I found this fascinating story of an obligation of parents to teach their children to swim. Why? Because drowning is an anticipatable hazard. And of course, infections are an anticipatable hazard. Kosher rules only apply to food, and they are not relevant to medications. From Mark chapter 7, I'm Catholic, by the way. That's my disclosure. Mark chapter 7, do you not see that Jesus, quoting Jesus, do you not see that whatever goes into a person from outside cannot defile? And he goes on, it's what's inside that defiles. Christian Scientist is, I believe, the only denomination where you would say there is a belief that there is no need to vaccinate. And it's because Christian Scientists do not believe that disease is real, is corporeal, you know, of the body, but rather an illusion by the devil. And so Christian Science practitioners are prayer leaders. They are not healthcare as we would otherwise regulate, or you all would regulate. And then in Islam, God is, quoting Muhammad, God has not made things that are unlawful for you to consume to be your medicine. I can go on. We can deal with this in questions. There's 1,000 ways to discuss this further. I'll just point out there's a religious leader in Rome who just got COVID vaccination a couple of weeks ago, and he described refusal to get vaccine as suicidal. And what he meant was that the vaccine recipients almost always have an obligation to others, to their spouse, to their children, to their coworkers, to the patients they take care of, and one should not throw one's life away at that. So let me stop. I thank you for your time, and be happy to work with you through questions. Shall I go strictly to Dr. Jacobson, or do you want how
I can take care of that. So thank you, Dr. Gravenstein. I just want to note for the record that Representative Franson and Representative Heintzman have both shown up, so they will be marked as present. As I mentioned at the outset, we'll hold questions until both presenters have concluded. I do have 4 members on the list, but we're scheduled to go till noon, so we should have plenty of time. So thank you once again, Dr. Gravenstein. Dr. Jacobson, please identify yourself for the record and then proceed with your testimony.
I thank you, Mr. Chair, members, for having me. It's an honor to present to Preventive Health Committee. I'd like to introduce myself. I'm a primary care pediatrician working in Rochester, Minnesota since 1989. I'm also the medical director for the immunization program for primary care in Southeast Minnesota in the 11 county region. And I have done vaccine research and more recently vaccine delivery research at Mayo Clinic over the last 3 decades. I'm going to speak to you on the success of vaccines, on vaccine hesitancy and current vaccine practices, a number of objectives. I'd like you to understand how vaccines have been a public health success, but how we have a public relations challenge. I want to speak to the 5 categories of vaccine hesitancy, and I'd like to speak to the origins and impact of the National Childhood Vaccine um, Injury Act that dramatically changed and improved our situation with childhood vaccines. Still to this day, it impacts and is the basis for current vaccine practices at Mayo Clinic and across Minnesota. Now, just as a thought experiment, ask yourself, which vaccine would you identify as our most successful one? And then take a look at this table. This is the annual number of cases in the US for a variety of preventable childhood vaccine preventable diseases. And you'll see over in the left-hand column the diseases. The next column is a typical year before we introduce that particular vaccine and the number of cases across the US that we would suffer with that disease. Then the second to the right column is a more recent year where we have a measurement of the number of cases in the post-vaccine era. Smallpox in 1920, 110,000 cases a year, now 0. Whooping cough or pertussis was 250,000 cases in the 1930s. We're down to 15,000 in 2019. Diphtheria, typical killer of school-age children in the 1930s, 30,000 cases a year, now down to 2. You know, tetanus is lockjaw, never was big in numbers, but 600 cases that really anyone suffering a minor wound or bite would fear. 600 cases a year in the 1940s, down to 20 in 1919. You look at polio, you see the 20,000 cases a year in the 50s, down to 0. Measles, 750,000 children in 1962, 1,200 in 2019. Mumps, 250,000 down to 3,500. Congenital rubella syndrome, 1965, 20,000 cases, often leaving the children deaf, blind, injured in so many ways. 2019, 0. Haemophilus influenza, an invasive bacterial infection affected children mainly under 5 years of age. When I was in medical training in the 80s, this was a horrific disease that we battled every day, 20,000 cases a year. Now, thanks to the vaccine, 14 cases in 2019. Acute hepatitis B, back in the 1980s, 75,000 a year would suffer a new case of this, often would go on to chronic hepatitis B. 2018, 20,000 cases. Chickenpox, 5 million cases a year in 1988. The year before I started my practice at Mayo, 2017, 100,000 cases. Hep A, 1995, 100,000 cases down to 24,000 cases. And invasive pneumococcal bacterial infection, children under 5, 16,000 cases a year in 1999. Only 1,700 in 2016. This is quite a litany of success. The most successful one, I'd argue it's the one that we no longer have to vaccinate against, smallpox, but others could find others. The Center for Disease Control and Prevention actually identified routine childhood vaccination in their top 10 list of preventive measures in the 20th century. In fact, first in that list. Cost-effective reduction of disease, eradication of smallpox worldwide in 1980. We stopped vaccinating against it altogether. We're getting close to eradicating polio worldwide, and we have the control of many other important diseases. The trouble with being number one is this successful suppression of childhood vaccine preventable disease has resulted in a fair amount of recklessness. We eliminated measles in the United States in 2000. Elimination means no longer is there a persisting chain of outbreak from one case to another that continued year after year. Every outbreak since 2000 has been the result of travel to the United States, and primarily US residents returning home to the States, and they're primarily unvaccinated, non-immune US residents. The number of cases in 2019 was 1,261. Outbreaks are just a plane ride away. And it's been a public relation challenge. I'm going to show you a very disturbing survey done in our neighboring state of Wisconsin. This included 1,000 parents whose children all were completely up to date with their vaccines needed for their school mandates in Wisconsin. 15% of the parents answered a survey saying it's better to develop immunity by getting sick naturally. 23% said their children get more vaccines than are good for them. 34% said immunity can be weakened by too many vaccines, and 34% of them felt unvaccinated children ought to be allowed in school among their vaccinated children. And these were the well-vaccinated children's parents. So we've got a public relations problem. There are 5 general categories of vaccine hesitancy. The vaccine might not work. The vaccine might not be safe. The vaccine might not be needed. Alternatives might be just as good or better. And the authorities might not be right. And almost every claim that I've heard a parent or a patient tell me a reason why they might hesitate, delay, or say no to a vaccine falls in one of these 5 categories. Now, frankly, as Dr. Gravenstein had reviewed, if you examine how vaccines join the routine vaccine schedule, you'll see that actually at every level, each category of hesitancy is addressed by the process. We have an independent science-based authority that determines, is the vaccine effective? We have that same authority examines the data for safety, for the need for the vaccine, and for the lack of competing alternatives. And only if that independent science-based authority finds all 4 to be true, do we routinely recommend that vaccine to children or adults. Now let's talk about effective. Now, we use randomized controlled trials with placebos. The blinding in the controls, the people getting the placebos, overcome the coincidences and help us prove cause effect. FDA licensure requires these randomized controlled double-blinded trials. In fact, they're tested using lot-to-lot consistent batches. So what was tested before licensure is still the vaccine that we're using today. It's tested with all the ingredients or constituents to be used when licensed. The manufacturer is not allowed to vary lots from lot to lot or change after licensure what they're doing with the vaccine. The test, the randomized control done is done at the age when the vaccine would be routinely administered. So if we're talking about an infant vaccine, its licensure trial was among infants. And it's also given or not with all the other vaccines already due at that age. That is, a new infant vaccine for licensure is tested only when given with the other vaccines. And it has to be shown to be effective in preventing disease to get licensed by the US Food and Drug Administration, or FDA. That second concern with hesitancy was safety. Those same randomized controlled trials pre-licensure show the vaccine to have an acceptable low rate of reactions, shown not to have persisting problems or injuries, and shown not to interfere with the other vaccines due at the same age. And the safety is monitored after FDA licensure for lot-to-lot consistency, and as well as maintaining surveillance systems for safety post-licensure, such as the Vaccine Adverse Events Reporting System and the Vaccine Safety Data Link and Phase 4 testing. And what about need? This is a big deal because the FDA doesn't examine the need for a vaccine. The FDA examines whether the vaccine is effective or safe, but we have a different group that determines need. It's demonstrated need epidemiologically in this country when and who are getting the disease and would need the vaccine. So it's not just that the vaccine has been licensed by the FDA as safe and effective, but it has to be graded as necessary. We have, as that independent body of experts, a US Advisory Committee on Immunization Practices, known as the ACIP. This group actually, since the 1990s, has been working with all 4 major national medical academies academies to get them to concur, such as the American Academy of Pediatricians and the American Academy of Family Physicians, the American College of Physicians, American College of Obstetricians and Gynecologists. You need to know not all FDA licensed vaccines get recommended for use. And the ACIP also decides when we no longer have to give the vaccine because they're no longer needed. Then we pull the recommendation and stop using that vaccine. The ACIP also determines if this vaccine is lacking reasonable alternatives. The FDA demands proposed vaccines work just as well. We have combinations in our neighbor to the north in Canada that are not licensable here in this country because they can't be as equivalent, they lack the equivalence with the individual vaccines. Furthermore, the ACIP requires vaccinations meet or exceed current alternatives. I'm going to give you some examples. BCG is a vaccine against tuberculosis here in the US. It has been licensed by the FDA as safe and effective, but the ACIP has determined it's not recommended for use given the alternatives available in the US for TB control or tuberculosis control. So we have a licensed vaccine that's not recommended because it's not needed. I'm going to give you another example. The pneumococcal conjugate vaccine, the 13-valent one known as by the brand name Prevnar, used to be previously recommended for everyone turning 65 years of age. We stopped recommending it a couple years ago. It's no longer recommended because the infant vaccination program with that same vaccine greatly reduced the adult risks. So we actually stopped a recommendation the last few years for that adult vaccine because it has a reasonable alternative. This independent authority, the U.S. Advisory Committee on Immunization Practices, consists of 14 infectious disease and public health experts. Minnesota has often had a member on this committee. And then in addition to those 14, one layperson representing the public. The ACIP meets throughout the year. It receives support from the Food and Drug Administration and the Centers for Disease Control and Prevention, but it's independent. It generates the only source of civilian federal vaccine recommendations for adults and children, and it standardizes use, dose, timing, contraindications, and precautions. Now, this table is a very important table for everyone in the room to understand. Over on the left-hand column, I've listed 4 of the critical aspects of vaccine hesitancy. Is it effective? Is it safe? Is it needed? Is it lacking alternatives? For our recommended vaccines, the answer is yes for all 4. We have the FDA licensure for effectiveness and safety. We have the ACIP reviewing epidemiology for the need and for alternatives. For the prescription drugs that I use every day as a pediatrician, my colleagues in internal medicine, family medicine use, we have the answers to effectiveness and safety from the FDA. But we don't have a national independent authority that examines the need. We often get a lot of look-alike drugs that get licensed for being effective and safe that really offer no new value, that are no better than what we already have. The alternatives are better. So for prescription drugs, we can't say yes to all 4. Over-the-counter drugs, it's even worse. Not all of those drugs have had any efficacy or effectiveness studies, and not all of the over-the-counter drugs have had safety studies, and no one is examining their need, and no one is examining whether or not there are reasonable alternatives to their use. And then over to the right, vitamins, minerals, nutritional supplements, because of federal law excludes FDA licensure and safety, those items on our shelves in our stores and in the medicine cabinets of our homes have had no studies of their safety or effectiveness. No one's examined their need, and no one is comparing them to reasonable alternatives. Vaccines are indeed our safest pharmaceutical or biologic we're using, our most and ones with the most demonstrated evidence for effectiveness, safety, need, and lack of alternatives. Now, the vaccine safety data link links the receipt of vaccines with medical records, and it connects 15% of the US population to an ongoing safety study. It conducts population-based investigations and upholds and extends the safety post-licensure. This vaccine safety data link has shown causal evidence that there is absolutely no association of vaccines with sudden infant death syndrome, absolutely no causal association with vaccines, including measles, mumps, rubella, or thimerosal, the mercury preservative once used in childhood vaccines, with autism. No mercury poisoning ever with thimerosal. It wasn't the type of mercury that actually accumulated in the bodies, and no autoimmune phenomenon associated with any of the vaccines we use. So what's happening with lawsuits and vaccines? Are there more each year or less? And why? It's important for you to know that this actually dates back to the 1980s when the diphtheria, tetanus, whole cell pertussis vaccine was a lightning rod for public concern. It was the old whole cell pertussis. It had a well-known reactivity, number of transient, local, and systemic effects, with a long-held claim of a rare but real neurologic harm that was rejected scientifically in the 1980s. There was no increase in large population studies of any neurologic harm from this vaccine. But nonetheless, DTWP lawsuits increased exponentially from the late 70s up to 1986 with 250 cases. And this brought about huge change. First of all, that year, 7 out of 9 diphtheria, tetanus, whole cell pertussis manufacturers left the marketplace in the US. Prices rose 2,100% a dose over a 10-year period. 255 lawsuits were filed in 1986 alone. Congress passed a law, Public Law 99-660, the National Childhood Vaccine Injury Act, that completely changed this and reversed a tide with its National Vaccine Injury Compensation Program. This program is funded by excise taxes on vaccines paid by manufacturers like Merck. It helps pay for the care of those seriously injured by vaccines, and it removes the adjudication of what is a vaccine injury that should be paid out from civil courts and juries. And it resulted in renewed vaccine production and resulted in tremendous innovation. Look what happened from 1986 on with lawsuits just descending and disappearing. And during the 90s, actually companies started investigating a replacement for diphtheria, tetanus, whole cell pertussis. It was far less reactive and much more acceptable. The National Vaccine Injury Compensation Program is a no-fault alternative to traditional legal system, provided financial compensation using evidence-based tables. There have been over 22,000 claims since it began in 1988. 4,000 were paid for doses given before that month, and 7,700 were found compensatable, and about 11,000 cases were dismissed. Now, these claims are out of over 3.7 billion doses of covered vaccines, and this compensation program complements two other important features of the Act. The first feature is the Vaccine Adverse Events Reporting System, or VAERS. It's a post-marketing safety surveillance program that's mandatory for every provider and every manufacturer. So I have to. In fact, I made a VAERS report this morning of a patient who got a vaccine administration error with the vaccine with our COVID-19 program. You report specific vaccines, reactions, and events. You also you can report other vaccines and other events. Anyone, a neighbor, a grandparent, an aunt can make a report. The vaccine information statements is another important part of this law. All healthcare providers must use a statement produced by the Centers for Disease Control and Prevention. There's one for each routine childhood vaccine. Before administration of each dose, you give it to the parent or legal representative of every child for every dose. Covered in that 2-page, easily readable form is why get this vaccine, who should get it, who shouldn't get it, what are the risks from the vaccine, what should be done for a reaction, what is the injury compensation program, and how can one learn more? Now, you might ask me, what is the primary challenge for vaccination as a preventive health measure? It's uptake. It's not outright refusal. Actually, only 1.1% of US children 19 to 35 months are unvaccinated, meaning they've never had any of the 10 vaccines due in the first 2 years of life. And that proportion's been unchanging over years. Most children get most of the vaccines recommended. The school mandates that we have in Minnesota and across the country act primarily as prompts. 95.2% have received 2 doses of measles, mumps, rubella by school. And that's up from 80% at 2 years of age, in part because of those school mandates acting as a prompt for the parent to get the vaccines due. You want to know what the biggest risk factor in Olmsted County is for being under vaccinated? It's being the third born or fourth born child. Busy household, family gets less interested in the well child visits with the well-meaning pediatrician and family physician, child gets under vaccinated. The school mandate helps prompt the parent to bring that child up to speed. The challenge is uptake. There's 11,000 births every day in the US. 13 vaccines are due in the first 18 years of life. 24 injections, 3 oral doses by 2 years of age, 8 more by 6 years of age, 12 more flu vaccine doses for the next 12 years, 3 more vaccines for teens as well, 5 doses in all. And this pandemic has made things much more worse. You saw the interruption with everything in March and April. We saw a drop, 70% drop in MMR vaccination rates early on, thanks to the COVID-19 interruption of regular life, including regular preventive care and health visits. This busy figure shows for all of the vaccines that we vaccinate in children in the first 2 years of life, how they're doing. Up here with the maroon is that DTP, now with the acellular form of the pertussis. You see the blue line representing MMR above 90%. These lower figures showing, say in 2001, the introduction of that PCV vaccine, getting up to a rate of about 85% now, the new hepatitis A vaccine, the new rotavirus vaccine. Our big problem is getting all these vaccines in when they're due in those children. And that's the big job ahead of every family physician, family nurse practitioner, pediatric physician, and pediatric nurse practitioner. The issues are uptake. Now we have issues with affordability and availability, disagreements in the routine schedule, misunderstandings about contraindications, the sheer complexity of all those doses and ages, opposition from the anti-vaccinationists, and then that vaccine hesitancy in a large plurality of parents. How do we deal with it all? Well, frankly, Minnesota and other states using the Vaccines for Children program have really solved the problem of affordability and accessibility. Vaccines are free to those providers who serve eligible children. It covers the recommended routine vaccinations. The CDC contracts with the vaccine manufacturers, and the CDC buys the vaccines at reduced rates, provides it to the states who enroll providers. Eligible children get the vaccines for free from the provider, and it complements the Affordable Care Act's first dollar coverage for preventive services like vaccines. The Vaccines for Children program was created in '93, executed by the states like Minnesota. It serves over 40% of US children in their own medical home. Before this, I used to have to send my patients who couldn't afford the vaccines to public health to get their vaccines. Now we keep them in our practice. They don't have to go anywhere to get their vaccines. Eligible children 0 through 18 years of age who are uninsured or underinsured, Native Americans and Alaskan Natives, and Medicaid recipients all participate. And the ACIP determines which vaccines are covered. The ACIP has also solved our problem of disagreements with the schedule by a harmonized schedule that the Centers for Disease Control and Prevention publish, created by the Advisory Committee on Immunization Practices with the support of the 4 major academies, including Pediatrics and Family Physician, published widely and online and updated at least annually. The contraindications, oh, we used to see so many silly ones, so many ones that had no basis in science. Most ones believed and practiced are false. Few true contraindications exist. These are prohibitions, people who should never get the vaccine. We've had a complete reversal in the belief about the role of acute illness. We now recognize that you can vaccinate a person with a mild illness, with or without fever, and that multiple vaccines don't weaken, never ever weaken immunity. So we now use every visit as an opportunity to vaccinate. Our current vaccine practices, we rely on the independent authority of the ACIP for its review and recommendations regarding effectiveness, safety, need, and lack of alternatives. We use a single standard vaccine schedule the ACIP publishes. We catch up children on missed and late vaccines as soon as possible with every visit. And we apply only the true contraindications and precautions, using every visit to review vaccines due and vaccinate, provide the parents the official vaccine information statement, and report adverse events the Central Federal Authority, VAERS. So in summary, vaccines have been and are a public health success. Vaccines, however, have also been a public relations challenge. 5 categories of vaccine hesitancy persist. We can address them all. The National Childhood Vaccine Injury Act continues to protect and support us in our efforts. The current vaccine practices reflect the science that support vaccines while putting that act to use. Thank you so much for giving me this time. And Dr. Gravenstein now and I are now available for questions.
Thank you, Dr. Jacobson. Appreciate your testimony. I do have, let's see, I have 4 members on the list, Representative Heinzman, Morrison, Grunhagen, and then Pryor. And actually I have a question as well. Hopefully I can get that in there, but I'll go to some other members as well first. So Representative Heinzman.
Thank you, Mr. Chair. I have 3 questions, and I'll probably just ask them one at a time. Hopefully we can get to them here. I'll start with Dr. Gravenstein. So one of the things you mentioned, talking about the safety protocols that are in place for vaccinations, which, by the way, super appreciated your comments. But one thing that popped up, in my mind is I hear from constituents who refer to something that wasn't discussed today, although kind of around the edges, and maybe you could give me a little more background on why vaccine producers were made exempt from liability and this other whole system was created. Why would we do that? And when did that happen?
So this was the National Childhood Vaccine Injury Act that Bob talked about. That's not quite right. If a manufacturer is negligent, if they intentionally did something knowingly wrong, you can sue them. And if you claim that the vaccine caused harm, you can sue. It's just that the federal government has stepped in to say, no, sue Uncle Sam first, not the company. And if in the discovery, they found out that the company was negligent, then they would turn around and go sue the company. But so you sue, but you go to the, Federal Court of Claims, and it's actually a no fault process where there's a table where the federal government has said, you show me one of these injuries and we're going to streamline your compensation. And then if it's not on that list, then we need to talk about it. But you can sue the companies. It just has to be for negligence.
Yeah, and I think, thank you. And I think Dr. Jacobson had a slide showing that the number of lawsuits decreased after the federal act was passed, but it didn't go down to 0. There were still some.
Well, in part of it goes over to that other system.
Mr. Chair. Thank you, Mr. Chair. I'll try again. The question was, when did that happen and why? That was the question.
It was 1986 or 7.
86, yeah.
Yeah. And why was because the manufacturers at that time were threatening to say, look, we can't stay in business. We're going to get sued out of business. And so the government said, no, it's in the public interest to maintain the vaccine supply. So then the government said, sue us instead.
Yeah, this was in Dr. Jacobson's slides. So Representative Heinzman.
Actually, thank you, Mr. Chair. That detail wasn't provided. So my next question was, when we were talking about, or you specifically, doctor, were talking about the COVID vaccination. You said that, and I'm gonna paraphrase, doing the best I can. I think you said you presume that the COVID vaccination will be licensed. That causes me a little bit of concern. Is there any doubt that it will be licensed? Do you have concerns that it won't be?
No, it's just, I've learned to be careful about predicting the future, and because I don't control it. I'm confident it'll be licensed. I think the odds are 99.99999%. I've read the detailed evidence that the FDA career scientists reported when they had a public advisory committee session at the beginning, with two of them, at the beginning of December, and it was 90-some page long reports, and I read the whole thing. And I haven't gotten vaccinated yet, but I'm looking for doses for myself and my family. So,
All right,
Representative Heinz.
Thank you, Mr. Chair. My last question, Doctor, was when you had mentioned that there's a number of groups, and I think it was in the discussion around the religious groups. There was one, I think it was Scientologists, I hope I don't get that wrong, but I'm just trying to
Christian
reference
Scientists.
your Christian Scientists, thank you.
It's a different.
That have, as a group, apparently decided not to be vaccinated, which that's neither here nor there. My question is, around that particular idea of there being groups of people here in the North American continent that have chosen not to be vaccinated. Is there any kind of research or any documentation you could send to my office? Just, I'm wondering, as we're comparing unvaccinated as a group compared to vaccinated, is there research that has, say, examined the one you referenced for cases of, say, for example, some of the big issues that
Measles
kind of
and
popped. Yes.
Yeah. So I mentioned that there have been 60 reports and increased rates of measles, increased rates of pertussis. I just, if I can take a minute, Mary Baker Eddy was the founder of the Church of Christ Scientists, the group that people call Christian Scientists. And she said in 1901 about, she said people don't, our adherents don't need to vaccinate, but she was quoted in the newspaper, I've got a reference here, rather than quarrel over vaccination, I recommend, if the law demand, that an individual submits to this process, vaccination, that he obey the law and then appeal to the gospel to save him. So I'll be happy to send that full article to the committee.
Any wrap up, Representative Heinzman?
Yeah, thank you, Mr. Chair. I appreciate that. So were there any other studies done, say, for example, we have increases in a couple of other conditions in children. Was that the only one, the mumps and rubella one, or was there any other research that was done comparing those groups that were completely unvaccinated from vaccinated?
So the comparisons of infectious diseases have shown, the preventable diseases have shown increased risk to the in the unvaccinated groups. Then from the safety of the vaccine side, there have been a variety of studies that looked at unvaccinated people without regard to their religion, just that they were unvaccinated kids, and compared them to vaccinated kids. And I'll make sure this lines up. The side effect rates are this much in one group and this much in the other group. They're the same. There's no elevation if you're referring to vaccine safety. Representative
Heinzman.
Thank you, Mr. Chair. I appreciate the extra time. I was specifically thinking about autism, Doctor.
Oh, so Bob may have access to a list of the studies quicker than I do, but it's been looked at in Denmark. It's been looked at in the United States. It's been looked at in a variety of places, and the rate of autism in vaccinated kids is the same as the rate of autism in unvaccinated kids.
Do you have any additional information, Dr. Jacobson?
Thank you, Mr. Chair. Yes, I do. I, in fact, was invited because of my connection with Mayo Clinic to meet with the Orthodox Jews, the Grand Rabbi, and the community in Spring Valley, New York, where there was a huge outbreak of measles just 2 years ago, involving, I think, in it. 1,200 people at that time, primarily among the practicing Orthodox Jews who did not believe in vaccination and feared measles vaccine would cause autism. Um, in fact, studies, as Dr. Gravenstein pointed out, I think we have now over 25 studies from around the world, huge studies showing absolutely no association of autism with the measles vaccine. I was able to work with the Grand Rabbi and that community to improve their vaccination rates and get the members. But yes, certainly groups that have gone unvaccinated because of religious beliefs have suffered much higher rates. In this country, even in the last decades, polio outbreaks uh, occurring among religious groups who refused vaccination. So it is real. It does happen. It is unfortunate. Every one of the vaccines that we work to vaccinate children leaves, when it's not given to a child, leaves that child at risk for that vaccine preventable disease.
Thank you. Representative Heinzman, I'd like to, this can be your last comment, but I'd like to move on to other
Yeah,
questions.
thank you, Mr. Chair. I apologize, but Dr. Jacobson, is there a specific study that you could point to that I could look at? I'd appreciate it because I've looked and I've had a hard time finding it, comparing a group of unvaccinated children versus vaccinated for incidence of autism.
Yes, I
Dr.
I
Jacobson.
can provide a number of those studies to Representative Freiberg to share with the committee members.
I'd be
I'll
glad to
do
share
that.
those with the committee. Thank you. Representative Morrison.
Thank you, Mr. Chair, and thank you, doctors, for your testimony. Dr. Gravenstein, I'm a physician and my husband is a former Army Ranger, so I know my family is particularly grateful to you for your service in many different venues. I wanted to thank both of you for highlighting and reminding us of the success story of vaccines, the really probably the greatest public health achievement, certainly of the last century. And as you noted, maybe except for clean water, and the fact that they really are sort of victims of their own success. Also grateful that you brought up and kind of walked us through VAERS, because I think that its existence is sometimes misinterpreted. And so I think it's really important that we had the opportunity to learn about the reason that it's there and how helpful it is to continue to keep vaccines safe. I'm also grateful to Representative Heinzman for referencing autism, because that seems to be a very persistent and tenacious misnomer, misunderstanding, because of that one study that has been long since debunked that came out of Great Britain. It's really been harmful in creating this idea that vaccines cause autism when we have all kinds of evidence that they do not. So I'm not sure I have a question. I don't know if either of you want to elaborate on any of that, but I just mostly wanted to thank you both for being here and for sharing all the information.
Thank you, Representative Morrison. I can just say, as somebody who has a person with autism in his immediate family, yeah, that I completely agree with you that that one study was decisively debunked. I believe the publisher of it lost his medical license as a result of it. So, I mean, it's bad on the science, but just on a personal level, I find it offensive. In my mind, it portrays autism as, you know, a disease that needs to be cured. And Representative Heinzman, I didn't get this from your question. I think you were just asking whether there were studies out there, and they answered your question. But I do find just the implication that autism is a disease that was caused by something external rather than a developmental condition, which it is. You know, I personally have an issue with. So anyway, I wanted to mention that. I don't know. Maybe you said you didn't have a question, so I think I'll just move on at this point. Representative Gruenhagen, you're next on the list.
Oh, thank you, Madam Chair, and I want to thank the testifiers too. I'm a lay person, like most of us, and just as a note, I and my children have been vaccinated. Back when I was in the Marine Corps, they were getting me ready to go overseas. I got numerous vaccinations, so I do think historically vaccinations has successes, and I just wanted to put that out there. Now, last year in the Health and Human Services Finance Committee, we had testimony by pro vaccination people and also parents with concerns. And the one that really, and I tried to attend some private groups to hear both sides of the issue. As an elected official, I get input from both sides. And of course, I was a previous school board member, and vaccinations or children who weren't vaccinated were a concern. But during that testimony, three Somali moms testified, and each one of them had an autistic child that seemed to develop after the vaccination, according to their testimony. Now, the interesting thing that they shared is that in Somalia, they have no word for autism. In other words, it doesn't exist for some reason. I thought that was interesting. And really, based on their testimony and some of the testimony of the other ones with concerns, it really came down to three issues that I think if we addressed, we would greatly reduce the resistance to vaccines. And here are the three issues. Again, regardless of where you're at on this issue, these are the concerns. Number one, the age at which that vaccines are given. In other words, I think it was Dr. Jacobson said 24 vaccines and 2 oral at, before 2 years old. Coupled with that is the second one. The concern is not only the age, but also the number given at one time. Some of the experts they referenced, and they have their experts too, on said that giving too many vaccines at too young of an age, when the child's immune system isn't completely developed, is, they use the word dangerous or unhealthy. And again, I'm not saying I agree with that. I'm just telling you what their concerns were. Okay. So, and the third thing that they were concerned about were the ingredients or elements in the vaccines. In fact, I have a bill that vaccines have to label, that I'm bringing forward, that vaccines have to label the ingredients that's inside the vaccination. Now, again, whether you're pro or have concerns about vaccinations, if you address those three areas, I think the amount of resistance to vaccines that has that's out there would be greatly reduced. I got one more question after that, but I'd just like to hear from the two testifiers what their thoughts are on that.
Who would like to take this? Dr. Jacobson or Dr.
If Mr. Chair, if you'd allow me, I guess I'd like to start. First of all, you should know as a primary care pediatrician, a good 10-20% of my patients are Somali Minnesotan. You should also know in Rochester and Olmsted County, our Somali Minnesotans have as high or higher rates of MMR vaccination than our non-Somali Minnesotan patients. I have a fair number of my patients who have autism. Actually, a study done at Mayo Clinic using the Minnesota State data is one of the 25 or so major studies showing absolutely no association of autism with MMR. Our own rates in this state of MMR, including when we doubled it and started giving a second dose, show absolutely no association with our rates in Minnesota of autism and autism spectrum disorder. The main impetus for what seems like an endemic of autism actually has been a change that has facilitated how primary care providers can diagnose autism and the requirement that schools provide services for autism. So So I preface my remarks with that. First of all, let's tackle the timing of the vaccines. We give those 24 doses of vaccines in the first 24 months of life because they're needed right then. I was a practicing pediatrician before we had Haemophilus influenza B vaccine, and every day we were struggling with febrile infants who might or might not have had Haemophilus influenza, and we would get a lumbar puncture, a blood culture, a chest x-ray, and tap their bladder for urine and hospitalize them for 2 days with ampicillin and gentamicin while waiting for their blood cultures and spinal cultures, fearing that they might have Haemophilus influenza. When we started vaccinating with Haemophilus influenza, one of the vaccines we give at 2, 4, and 6 months of life, and then 15 months of life, we wiped out Haemophilus influenza. Most parents, most young pediatricians have no idea what I'm talking about, the 20,000 cases we had a year. We give those vaccines when they're young because that's when they need it. I wish I could give the measles, mumps, rubella vaccine earlier than 12 months. The reason I don't, their bodies wouldn't notice the vaccine if I gave it at 6 months because their maternal's immunity from the mother's vaccine would actually prevent their body from noticing it. Um, in fact, we vaccinate with hepatitis B as soon as a baby's born because the risks babies have of acquiring hepatitis B from their mother or from the household. And we have dramatically reduced the chance of that child having lifelong hepatitis B from an environmental exposure, maternal exposure. So that's why the vaccines are given when they're young, because they're desperately needed then. Second question, what about way too many vaccines given at once? When I was a pediatrician in training, I would walk in the room with a little frozen packet of the oral polio vaccine and with a syringe of diphtheria, tetanus, whole cell pertussis. In my pocket, I carried more antigen than a child gets in Minnesota after 5 years of the current vaccines we give. The antigens that I had in my pocket to give at that 2-month visit exceeded all of the antigens we now give with our much more refined vaccines. So we've actually reduced the amount of immune exposure we're giving our babies with our current vaccine program that was in part inaugurated by that public law I referenced in my presentation. In fact, back when we vaccinated against smallpox alone, we gave 3 times the vaccine that I used to give with that whole cell pertussis and the polio vaccine. So I would say we're giving less vaccine now in terms of immunoactive agents than we used to. They're all given then now because they're needed because of the baby's risks at that time. You asked a third question, and that was about the ingredients. One of the tricky parts about vitamins and minerals is that no one's regulating their day-to-day manufacture or checking lot-to-lot consistency. Mayo Clinic here in Rochester, Minnesota has over the decades demonstrated how certain vitamin and mineral combinations sold over the counter actually were poisonous and we're hurting our Minnesotans and others. We have no FDA monitoring the vitamins and minerals from lot to lot consistency. But when Merck makes a vaccine for licensure, the FDA is in its face checking the manufacturer, checking what's in each lot. The reason we didn't have a chickenpox vaccine from 1970 to 1990 was because Merck couldn't get lot to lot consistency to work. The ingredients that are in the vaccines are few and rare and small, but they are consistent and they are every single dose, every single vaccine. All those safety studies were with those vaccines. I don't know how a list would help a parent make a decision. But I will say at least they're not changing from lot to lot, and what we have licensed is what we're getting now.
Thank you. That was a very thorough answer. Representative Gruenhagen, I have a couple members on the list. Can you?
Real quick, my next one is real quick. Yeah, the ingredient thing or element thing would help quite a few of the parents would lower the resistance, I think. Anyway, just for your feedback. The final question is, I've been trying to hear both sides of this COVID-19 discussion and those who are concerned. We have statistics that only 30 to 40% of healthcare workers, has been reported on the news, actually have taken the vaccine, and that a significant percentage have resisted it. Those who resist the COVID-19, they're saying it's an experimental vaccine that takes a different approach in terms of vaccinations than what we did in the past. I've watched a few experts explain that. Just give me a perspective. Is this COVID-19 vaccine, which was developed under a Republican president, by the way, is it experimental in terms of the approach it's taking, or does it follow historical trends in terms of the development of the vaccine? That's my question. Thank you, Mr. Chair.
Start that if I might.
Sure, Dr. Gravenstein.
So the two vaccines that are probably being used in Minnesota today, Moderna's and Pfizer BioNTech's, are the active ingredient inside the syringe is a little piece of protein called mRNA. It's like a blueprint that tells your body to make a protein. You have mRNA in your body right now. If you cut your finger, you couldn't heal the finger if you didn't have mRNA. If we took the mRNA out of your children, they wouldn't grow any taller. It's natural. So we're just harnessing a natural system. So, but it's the first time vaccines have had it. So it's new in the sense that it's not been in a vaccine before, but it's been well tested. 30,000 people in the clinical trials. That's the same as Shingrix, the shingles vaccine, the size of its trial. And now it's been in 20 million people. And so suddenly we have a whole lot of safety information on it. So experimental, well, it's not fully licensed, but it's an emergency. It's an EUA, but it's well studied.
Okay, thank you.
Okay.
Mr. Chair, may I add something to that?
Dr. Jacobson, quickly.
In Mayo Clinic in Rochester and across our enterprise, 96% of the physicians have opted in for the vaccine, 96%. Yes, in other healthcare workers, including the secretaries, the clerks, the technicians, the rates are lower, but they're much higher than 30% now. They are, in fact, they're well over 50, 60% now. I take issue with experimental, Mr. Chairman, because while it was an emergency use authorization that rushed it through, the FDA required the company submit the same phase 3 trial data, the raw data, to the FDA for submission. So there were no corners cut with the licensure process that got the FDA to issue the emergency use authorization. What the FDA really did was just rush the process, rush the meetings, rush the information. But the actual data they required, they demanded the same level that they would demand for licensure.
Okay, thank you. I'm going to go to Representative Pryor.
Thank you, Mr. Chair, and thank you for this hearing this morning. There's a lot, for me, there's a lot of new information. This is something that I knew in general about how a vaccine is developed and then actually gets into people's arms and the importance of it. But to hear, there's parts of it that I did not know about. And so I just want to check my knowledge and my understanding of that right now. How there is the transparency and the checks and balances from when an idea is first developed to actually it being put into a baby's arms. So you have the pharmaceutical company that has developed the ideas. They use animal studies, they use the basic science, they start developing the trials, and then they keep producing this data. And then as that goes out into these large population trials, much more than any other kind of development of a medicine. These large trials, they're collecting the data. Then it's the FDA that reviews the data and is responsible for that step of there. So they're the ones that are checking all the boxes, making sure that everything makes sense. And if it's wrong, if something's missing, they send it back. And so that was your slide with even the physical check marks. But then after that, the FDA licensing, which says, yes, it is effective. Yes, it is safe. There's another group, and this was new to me, which, and I'm glad to know about it. It's the Advisory Committee on Immunization that takes it that other step, which is saying that, yeah, there could be other treatments. And so maybe this vaccine, which you're giving to healthy people, as you said, to preserve their health, there might be, better ways of taking care of an illness. And then they are ending up being responsible for those other steps, which is to say, is this something we need? And are there other alternatives? So, if that's, and I saw nodding heads, and so I appreciate that. Essentially, on a high level, that's a new understanding that I have right now, and appreciate that. And it, there's a level of security that not that I needed more security, but now I feel that I have it. So that being understood right now, tell me a little bit more about that phase 4, which is how we keeping track of this information, and we keep watching the populations as of people that have been vaccinated and not vaccinated, and keep comparing it. Who's responsible for phase 4? Who's funding phase 4? And how does that work?
If you could do it quickly, Dr. Gravenstein, I'd still like to get to a couple more questions.
Sure. So I'll also just say that FDA doesn't just take in the information from the manufacturer, they recalculate all the numbers to see if they can reproduce the same numbers. My slide 11, which was the vaccine safety monitoring, without that real small print, and then my ranking by scientific power, that is the phase 4. Those are the specifics of the phase 4 studies. And those studies are largely done by the government and universities. Mayo and University of Minnesota are contributors to projects of a variety of sorts. And the manufacturers also have an obligation to take in all the information they can get from Merck as a multinational. Most of these companies are multinationals. They have an obligation to report to FDA what happens overseas, so that it's full disclosure.
Thank you. I'm going to go. We have to end at noon in 3 minutes because of the live stream limitations. So I'm going to go to Representative Agbaje.
Thank you, Chair, and I'll try to make this brief. I want to address what I didn't really quite hear in the presentations, but I think Dr. Jacobson kind of alluded to this a little bit, is how is the engagement with various communities of color around hesitancy around vaccinations, which we know rightfully so based on the history of the medical community. But how has that engagement gone in a way to ensure that these communities understand the efficacy, the safety, the necessity of vaccines, and how it will protect their children in the future? So if you could just speak really quickly to that.
Dr. Jacobson, so you unmute yourself.
Mayo Clinic, along with Olmsted County and the State Department of Health, actually have been conducting town hall meetings. We met with the Somali Minnesotans of Rochester during the crisis with the measles outbreaks a few years back. We are now holding similar ones regarding COVID-19 vaccine, and have so far met with the African-American community, the Arabic community, the Somali Rochester community, and the Cambodian community in town hall fashions, where we can really, for an hour and a half, hear people's questions, often with medical interpreters, and answer their questions. Only by really listening and talking are we going to help people get understanding of the question of what they need to say and what we need to hear.
Thank you. I don't know that Representative Heinzman, I see you raised your hand again. I also had a question, but I don't think we have time for them, unfortunately. Is it okay if members follow up with you with questions, Dr. Jacobson and Dr. Gravenstein? Okay, you're both nodding for the record, so I'll make sure that members have your contact information as well as I do myself. So we have to end momentarily here. So next, I'll make sure you get notice about the hearing for next week. but it's likely we will be taking up a bill or two, potentially two, for the first time at our hearing next week. So any questions about the schedule from members? Okay. Seeing none, we are adjourned.